So Tom had to step out, so he deputized me to introduce James Yu, who many of you know is on the faculty in therapeutic radiology, specialized in CNS and prostate, and is also an integral member of the Yale Center, which is cancer outcomes, public policy, and effectiveness research, and that's the area he's going to talk to us about.
I have to present him with this award.
Thank you. Thank you very much, Dr. Engelman. And you're a very tough act to follow. But if I talk quickly, put your hands up and slow me down. The title of this talk is mainly about the economic costs associated with prostate cancer and radiotherapy. But it's work that we've been doing in the Copper Center, trying to look at trying to tease out the reasons for why cancer treatment can seem so costly and what the relative societal benefits may be. I have no financial disclosures or conflicts of interest, other than I am a radiation oncologist. A lot of my friends are radiation oncologists, so I believe that radiation is a very effective treatment modality. I also am a father, so sometimes the two sides can seem in conflict because I don't want my kids to pay for my health care. So because of that, we decided to look at the cost curve in general. We've been hearing about this for several years now, and also to do some illustrative case studies. I can't talk about all of the studies that we've been doing, but I'm just going to focus on the prostate cancer side. And I'm not going to talk about prostate cancer screening, which I know was part of the initial background for this talk. And then we're going to talk about the changes to radiation oncology costs in general, and then looking beyond costs. Hopefully, after the recession, after such a great focus on how much medical care costs, maybe we can focus back on cancer disparities and what the true price of cost controls can be. So the first question is, what is the cost curve and is it bending? It's a bipartisan issue. Everybody believes that healthcare costs are a ticking time bomb. Spiraling costs must be brought under control. And this was a very major theme of both of the past two presidential campaigns. And the idea is that this cost of healthcare is going up year after year after year. The growth of healthcare continues to be high. And the worry is that it's going to continue forever and it's going to eventually become unsustainable. So the idea is we have to bend this cost curve. That's what people talk about when they're talking about bending the cost curve, is reducing the growth in national health expenditures. So what's the problem? Well, healthcare spending is about 17% of GDP. It's the highest percentage of spending in the developed world. And it seems to be going up even in 2007, 8, and 9, which are the recession years. But if you take a closer look at it, the actual yearly growth in U.S. spending on healthcare has actually declined in the recession. So what happened? That's actually the only joke slide. I gave an hour-long talk in therapeutic radiology grade rounds. I had to take out a lot of those slides. So what happened? Well, during the recession, U.S. healthcare spending, the growth, the delta, the growth in healthcare spending actually went down during the recession. Unfortunately, so did the GDP. So the cost curve is bending in general. The overall healthcare cost does seem to have declined. The overall growth in healthcare costs seems to have declined in the past couple of years. And President Obama mentioned this during the 2012 debates. He misspoke. He said premiums, not costs. But what he meant to say was healthcare costs have gone up slower than any time in the past 50 years. So something has happened in the last 3 to 4 years, slowing the rate of growth. So where has spending slowed? Well, the main area where spending has slowed is health administration and insurance. But if you take a closer look, the big chunk is outpatient care. And this is where radiation oncology sits, mainly. So the question is, okay, we've tackled health administration and insurance. Is the cost curve bending for radiation oncology? And besides, it was a recession. And healthcare spending usually goes down during a recession. Big deal. Well, and it's a cyclical thing, you know. So as the economy picks up, we'll just start spending again. Well, if you look at something called potential GDP, which is not the actual GDP, but it's the GDP that would have been in a perfect economy, you can actually get a better picture of how healthcare spending has evolved during that time without the artifact of the recession. And if you take a look at potential GDP, what you find is that healthcare spending growth actually declined in 2005, several years even before the recession. So what's going on? There may be something going on besides a recession. It's this idea of structural change versus cyclical change. You know, some observers expect this to bounce back when the recovery becomes more robust or when the Affordable Care Act becomes fully implemented. But there may also be structural change involved. It could be a new era of physicians in you know, the late 2000s. There are multiple editorials about how the newer physicians are more interested in lifestyle and not interested in practice building. This idea of perhaps the hospitals are getting more efficient. Prescription drug spending may be decreasing. We'll talk about that in a minute. But another powerful idea is that this marginal utility has gotten smaller, meaning we spend a lot of money on healthcare. The market has finally decided additional dollars is not going to help. Regarding pharmaceuticals, over the next 5 years, there's going to be a whole swath of medications becoming generic that are extremely expensive at present time. About $21 billion worth of pharmaceuticals that will be going generic. And just try and keep that number in the back of your head about the sheer size of medication costs. But, you know, that said, there may be some pushback from drug companies to prevent some of those medications from becoming generic. And again, the size of the dollar figures here can be astronomical. And this was just out today, so a lot of the biotech companies are pushing back on biologic medications going generic. But just to recap this whole background section, excess growth did diminish. It seemed to predate the recession. And spending on physician services actually grew slower than the growth in potential GDP predating the recession. So now what about radiation oncology? Are we bending the cost curve? Radiation has gotten a lot of scrutiny as an expensive and getting more expensive treatment. This was in the New England Journal looking at the rate of spending growth within each discipline compared to the sustainable growth rate, or SGR. And they pointed radiation out as the biggest offender of the radiation, of the hole in the sustainable growth rate, why medicine in general couldn't keep up with predicted growth. And Arnie Konski wrote a paper about the IMRT delivery charge as being responsible for over $1 billion of treatment. So radiation has been targeted. So because of that, we decided to look into the historical trends in radiation oncology and look at prostate cancer and examine the trends in new treatment and in particular proton radiation therapy, just to see if all of these alarm bells were ringing for a true emergency. So looking back at historical trends in radiation oncology, you can see this is the overall curve for the number of patients treated with radiation since 1973. And you can see that there's a dramatic growth in the number of patients treated. Ignore the absolute number since this is from a portion of the country. But in general, the reason for this rapid increase was from the rapid rise in radiation usage for breast cancer that happened in the 1980s, the large bump that occurred with prostate cancer screening, and then subsequent rise. So after you look at the impressive rise, you can see that the number has actually relatively plateaued during that period that they were worried about in the SGR study. You can see that though the number of patients has plateaued, during the period of medical costs going up, radiation seems to have kind of leveled out. This is a bit of a busy slide, so let's take some of those away. And this is the percent of patients undergoing radiation therapy as a component of their initial care. And you can see that lung cancer, the percentage of patients getting radiation has actually gone down in the past decade. The percent of patients getting radiation for breast cancer has gone up dramatically, as we talked about, and then leveled off. And then prostate cancer treatment has actually peaked and gone back down. This seems to be in the area of robotic prostatectomy, perhaps, or a more focus on active surveillance, perhaps. But for some reason, the percent of patients getting radiation for prostate cancer has gone down. And so in general, the proportion of patients getting radiation in general has plateaued around in the late 90s, early 2000s, and actually gone down. So we know that the cost curve has plateaued. We know that from 2003 to 2009, the radiation expenditures exceeded the sustainable growth rate by about 300%. And we know that the number of patients being treated has plateaued. So are we treating more expensively? This is a study that we did looking at the types of treatments that patients are getting. And this teal taking over the navy blue is intensity modulated radiation therapy, taking over for 3D conformal radiation. And you can see that the relative trends in the number of patients has been stable. But there's been a more newer treatment being used. And then we know that newer treatment does cost a little more money. This is a paper by Paul and Nguyen out of Harvard. And IMRT is more expensive than 3D conformal radiation by about $10,000 or $11,000 according to Medicare. And that adds up to about $280 million in general. So we know that we're treating more expensively, but we don't know if that expenditure is justified. Because this $280 million could certainly be justified if there are enough improvements to a patient's quality of life, improvements in cure rates. And Dr. Konsky has done a cost-effectiveness analysis. And basically, it does seem to be cost-effective if you go by the $50,000 per quality-adjusted life year limit. So it's possible that IMRT, even with this $280 million of extra expenditure, is indeed worthwhile for prostate cancer, which led us to say, what about proton radiation then? So proton radiation is an emerging treatment for men with prostate cancer. We know it's more expensive than the standard of care of external beam radiation and IMRT. But protons are a very exciting treatment in that there's a physical property called the Bragg peak, where a proton penetrates into tissue and then delivers its radiation dose at a depth that's predefined by the energy of that particle. So any charged particle with mass has this property called the Bragg peak, and the proton is massive enough that it doesn't scatter as much as an electron. So it's almost the perfect particle for treatment. But IMRT itself has a very large and robust literature describing excellent efficacy. So the question then comes up, there's no randomized trial comparing proton radiation and IMRT. So can we do other studies looking at large patient registries? And two groups have looked at the SEER Medicare data, and they found that proton radiation was actually had an increased rate of gastrointestinal toxicity by their registry compared to IMRT. So this much more expensive treatment had a higher rate of toxicity than IMRT. The study was a little flawed, though, because within those SEER regions that they looked at, which is the registry that they used, there was only one proton center. So they were basically comparing one proton center to the rest of the SEER regions. So there was a bit of a selection bias. And it's a lot of people looked at these results with a little bit of a jaundiced eye because you don't expect protons to have a worse toxicity than IMRT. So we thought there was still a lack of data regarding the true national patterns of use. And so we decided to look at the whole country. And we wanted to look at the cost to Medicare and to measure the incremental difference in complications. Basically, we wanted to do it right. And so we looked at the Medicare Chronic Condition Warehouse, which had 6 proton centers. And we matched on patient level and regional variables using a random effects logistic regression with clustering by HRR, because these are 2 levels that you have to match to, the regional level and the patient level. And then we mapped it out. And we also calculated the cost using the sum of all Medicare reimbursements. And then we compared proton radiation to IMRT in terms of toxicity. And these were our a priori groups of toxicities: genitourinary, gastrointestinal, and other, with standard side effects that you may see when you treat someone with prostate cancer. And we tried to clean the data up as much as possible. And we included patients with at least 6 to 12 months of follow-up. And we matched using a propensity score match. And what we found were proton radiation patients were much more likely to be white, younger, richer, with less concurrent androgen deprivation therapy, meaning probably with earlier stage disease, and healthier. And we also found that patients traveled extremely long distances to get proton radiation. You know, some folks from California traveled to Indiana, folks from Massachusetts traveled to California. So there's this whole strata of the cancer patients who are traveling around the country for the very best care. And we also found that proton radiation was much more expensive, and that although in the short term there is slightly less genitourinary toxicity than IMRT, which we expect, we expect there to be less toxicity with this much more targeted particle. We found that when you go out to 12 months, those complications go away. And this was actually very gratifying because at the same time that this analysis came out, a patient-reported outcomes paper came out, which basically said the same thing, that the side effects from proton radiation are transiently better. And that's basically what we found. So limitations of this analysis: it's a claims-based analysis, that we didn't have staging information, we had short follow-up, and we only had a couple hundred proton patients. But in conclusion, folks getting proton radiation are younger, more likely to be white and rich, and not receive radiation therapy, androgen deprivation, and they travel substantial differences. So you have to try and match patients as closely as possible, because these patients are likely to have, be healthier. We also know that proton radiation is more expensive. We also found only a modest and transient reduction in genitourinary toxicity for patients undergoing proton radiation versus IMRT. And obviously, continued longitudinal studies is needed, and a randomized trial is occurring right now. And I hope they accrue patients, but I don't know how they could, because someone who travels to Mass General and wants proton radiation isn't going to be randomized easily. So what we know is we are not treating a greater number or proportion of patients. We are treating more expensively, and proton radiation does not seem to be justified. And this was picked up in the Wall Street Journal. And just to let you know, this whole cost effectiveness is a very touchy subject. And the comments that we got based on our study were all over the map. And we really were just trying to do a scientific study where we didn't know what the answer was going to be. So putting it all together, during the period of the SGR hole, radiation costs have gone up. And you can see, even though the proportion of cancer patients is relatively stable, costs per person have gone up. But in the last couple of years, things have actually stabilized quite a bit. So looking back at that IMRT code, things have actually stabilized in the last 3 years. If you add that IMRT code to all the other codes that we use in radiation oncology, because that code is so commonly used, it's a very expensive code. But altogether with radiation oncology, costs have actually been stable over the past 3 years. Furthermore, physician management, which is the main code that academic radiation oncologists bill, on the professional side, that's actually been relatively stable for the past 3 years. And actually going back to 2003, during that period of the SGR hole, again, costs have been relatively stable, so that increase is likely from technical or technology-related professional fees. Looking at the last 3 years in the context of Medicare, you can see that overall Medicare costs have gone up. And if you take that away and just look at other cancer-related or non-related, like ophthalmology, fields, costs have been relatively stable over the past 3 years with radiation. And I just put ophthalmology in there for contrast. So if you also put it in the context of the cost of new medications these days, that increase in radiation oncology costs seems to become less significant. Lucentis for macular degeneration cost $1 billion in 2010 for a single code. And you compare that with Avastin, and it's strange to be calling Avastin the cheaper option. And speaking of Avastin, it was $770 million in 2010. This could all be very justified. I just want to put that in the context of how much radiation oncology costs. And so the further I dug into it, the more that radiation oncology seemed to be a relatively cheap option, I guess. It's a renewable resource. And we all know that cancer drug approvals are accelerating also. So that's another piece of the puzzle in radiation oncology costs and cancer costs in general. So the next steps for us in the Copper Center are to see if the global trends will continue, to ask who pays the price of frugality in radiation oncology, and is there a more rational way to cut costs. This is a study we did looking at the density of radiation oncology facilities around the country, and you can see there are large areas where radiation oncology is not well represented. And we know that radiation oncology, having 0 to 1 or 1 to 2 or 2 to 4 radiation oncologists, your prostate cancer mortality your associated prostate cancer mortality is reduced, even when controlling for specialist density like urologist density, et cetera. The greater than 4 confidence intervals are relatively wide, and this probably indicates urban areas where there's the highest density of radiation oncologists. And we also know that rural practices are struggling, so across the board cuts to radiation oncology may have undue consequences. And we know that disparities in cancer still exist. In 2000 to 2002, compared to 1992 and 1994, there hasn't been much improvement. So we need to make sure that those traditionally underserved are not further underserved by this attention to cost. So in conclusion, the cost curve is bending overall. Radiation oncology is not the villain that was made out to be, at least in recent years. But we are rapidly adopting newer and less proven technologies. And whether this additional expense has resulted in an additional benefit is the subject of continued research. We're going to continue to look at breast cancer, lung cancer, prostate cancer, and brain metastases. And I thank you for your attention.